Dr. Eifler. It's great to see you again.
It's good to see you again, Don.
Thank you very much.
We're going to have a talk today.
Yes, we
Oh,
are. Hi, Dr. Eifler. As you know, I'm Don Fendon, and I have a client that I want to send to you with a rotator cuff tear in his shoulder. Can you tell me what you would do to take care of it, how you would treat it?
Yes, sir. Well, it's good to see you again, Don.
Good to see you again, too. Always a pleasure.
My pleasure. So this is a shoulder, as you know. It sits on the body like so. And we have different structures inside the shoulder. We have the humerus, which is the arm bone or the shoulder bone. We have the shoulder blade right here with the collarbone coming across the front, so it would sit on your body like so. The rotator cuff is made up of 4 muscles. You have the muscle in the front, the muscle on the top, and 2 in the back. The one on top is the most common one that's torn. It's called the supraspinatus. The biceps tendon comes up along the front as well and goes along inside and attaches deep inside the shoulder. The muscle in the front is probably the most second commonly muscle torn, called the subscapularis. So when this patient were to come in to see me, they would, after a fall off a ladder or a slip and fall, we would want to get an MRI. If the exam suggested they had a rotator cuff tear, the MRI would help show me what was damaged. We would discuss with the patient their history and kind of get an idea of their level of functioning and their level of deficit from the tear. Not every rotator cuff tear needs a surgeon. Some of them just need physical therapy and non-operative management, but some of them have to be fixed. If the rotator cuff tears and it pulls off like so, that means that rotator cuff is now pulled off the bone. It's never going to go back and heal where it was originally.
So how would they function with that, even after you did surgery?
Well, after we did surgery, what we would do is we'd take this muscle and reattach it back where it belongs, because we know that it's never going to grow back. And if we see them before surgery and they have weakness, they have pain and trying to raise their arm away from their body, such as this, without that muscle there, you can see it's an important stabilizer to hold the ball in the socket while the other muscles move around. And if it's not there, then it throws off the mechanics of the joint. So what we do is we do it arthroscopically through about 3 or 4 little incisions like so, in the front, the side, and the back, and we put sutures in this muscle and then reattach it to the bone. And when the process, like I said, is done arthroscopically, we take pictures before, we take pictures after. Sometimes we have to treat other things inside, such as bone spurs or torn biceps tendon. And then we start them in therapy usually within a week of surgery, and then follow them quite frequently to keep them in line to get them back to their high level of functioning. And of course, as you know too, a lot of these patients need physical therapy for a prolonged period of time. If they're a heavy labor type person, they're going to take longer to go back to full duty than someone who's in the office, because this muscle has to take time to grow back into bone. It just doesn't grow back right away as soon as we reattach it. And I tell patients, when we repair your rotator cuff, it's not like hanging a door on a door frame where you're done and you can use it as much as you want. This muscle has to grow back into bone, and that process takes several months to happen. And then to regain all the strength in the shoulder as well is very important. So it's a pretty significant injury, especially to the worker that does the strenuous work.
Is it always treated arthroscopically, or do you have to actually open up the body to do the shoulder surgery?
Sometimes you have to do it open if it's a very large tear, or you can't get it back to the right position arthroscopically. If it's been a long time since they got hurt in February, and maybe by the time they get through the workman's comp maze, they don't get fixed until July or August, that can sometimes make it be a more of an open procedure. But a lot of times we're able to do things arthroscopically to put it back together.
Is this the collarbone right here?
Yes, sir. That's the collarbone, and it sits, like I said, just like this on your shoulder. And typically, like I said, the incisions are rarely small. They're about as wide as your finger, so about 2 centimeters in the front and the side and the back. And therapy is very intensive to get them back to work.
Do you treat most shoulder rotator cuff tears with arthroscopic procedures, or what's the percentage of that as opposed to opening up the person?
Well over 95% are treated arthroscopically. And we treat also labral tears, slap tears, shoulder dislocations are also very common in the injured worker. And those structures that involve the labrum are underneath the rotator cuff muscle and are also treated, the vast majority of those are treated arthroscopically.
What is a labral tear actually?
The labrum if you look at the shoulder socket, and this model is hard to see it exactly, but if we take these muscles off and look at it, the labrum is this structure right here that goes around the socket. The socket is fairly flat like a golf tee, and the labrum acts like a bumper to fit around that. So if this is my socket, the labrum is a bumper that fits around it, and the ligaments attach onto it, and it helps hold that ball on the golf tee. Now, of course, it's not sitting in your body like a golf tee, it's sitting vertically, and so that labrum is here. When the person falls and has an injury, that ball will be pushed out of the socket, which will subsequently tear the labrum and pull it off the bone, and it does not do a very good job of healing back where it should. So arthroscopically, we have to go in and put in suture anchors that will hold the suture in place, so then we can tie the labrum back where it belongs and tie in the ligaments as well to restore the normal anatomy and function of the shoulder.
Do a lot of patients have pain down the upper extremity from the shoulder surgery? Because a lot of times you hear about them having neck pain as opposed to shoulder pain, and it radiates radiculopathy down the upper extremity. There's a lot of confusion about that.
Yeah, there is a lot of confusion with it, and sometimes people, when they fall, they can injure something in their neck as well as their shoulder. So if we have any indication that there's a problem with the neck involvement, we may get an MRI of the neck. We may send them to a specialist who specializes in the neck to help rule that out. Sometimes when you have damage to this rotator cuff, it will put pressure on the nerves and they will get some pain down in the arm that then will resolve with surgery.
Well, thank you for explaining that. You're a fine person, and everybody in town, you have a great reputation with the other doctors.
Well, I appreciate that, Don. It means a lot. And, I think it's guys like you help the injured worker get back to work, to navigate through the maze that workman's comp is. And when I see a patient from you or your colleagues, it's really helpful because it helps those patients get back to work and get through the maze of what the workman's comp is. So I appreciate that.
Thank you very much,
All right.
Doctor.